Cindy, it's not hard to agree with you on many aspects you mentioned. And more than that, these are my disclosures. Here is, first of all, to recognize you for your numerous achievements in the aspect of STEMI interventions. On this matter, we disagree, and let me explain to you why. I think to explain or dismiss this amazing trial as a matter of chance would be wrong. I do believe, and I agree with you, that the numbers are extremely small, but I think this is an amazing trial which is demonstrating clearly a reduction in not any of the soft endpoints, but the true hard endpoints of death, MI, and refractory angina. And I think the true contribution of Dr. Wald and his colleagues is that it has set up the field for what I think is one of the most important answers in STEMI interventions. But let's remove this hype and all the fear and all the other doubts which some of them you have raised, but I think they are more relevant to the times when we used to do balloon angioplasty. So what are the issues? I think first of all, the reason this topic is so important is because STEMI interventions are now becoming the commonest procedures in most cath labs globally. And I think the biggest flaw in our thinking is that we are applying guidelines. You mentioned the New York State Registry that was published in 2003. A lot has changed. We are doing TAVI, drug-eluting stents, OCTs. It's a totally different environment. And I think it would be unfair to deny the enormous amount of convenience, logistic, and financial benefits, not only to the patients, but that accrue to interventional cardiologists. This is what happens when you perform staged PCI during a STEMI. Let me take you beyond New York into the rest of the world. So this is a poor patient in India who unfortunately has a STEMI, and at the end of the STEMI, this is what he has to sell. So now we say, look, let's leave the non-culprit straightforward RC alone and bring him back, and we do that, and this is on sale. I think the economic benefits which come to us from performing a lot of these procedures simultaneously are too numerous, too important for us to dismiss easily. These are some other critical observations which I think lend a scientific basis to our doing a complete revascularization. The wonderful observations by Goldstein that whenever you have an inflammatory reaction during acute coronary syndromes, including STEMI, it is not limited to the lesion but to the entire vessel, and possibly it makes justification to fix that. We are also dealing with the era of drug-eluting stents, all sorts of improved methods to prevent contrast-induced nephropathy, 2B3A, many other methodologies and treatments, all suggesting we are dealing with a totally different ballgame where performing a second lesion is not going to be terribly time-consuming or use too much dye. Let me share with you some more data. Now, Dr. Grimes did show some trials, and it's hard to make an inference from randomized trials which enroll 214 patients. And a lot of these patients, if you take a look at it, staged PCI was allowed, as Dr. Grimes showed in a few of her concluding slides, which kind of exaggerates the benefits of doing only a culprit vessel PCI. This is to explain this confusion further. This is the data from the Swiss AMIS study, and if you take a quick look at it, in the initial presentation you realize that the benefits are equal and probably one should be headed towards doing culprit only. Then you take up the data and remove from it the high and the low risk, and at the end of it you realize that when you are comparing the two together, there really is not much difference. So I'm not so sure that doing a culprit only minimizes the risk any meaningful way. So here are some more randomized clinical trial. I'll run you through 2 trials and 2 meta-analysis. This is the first one by Karawani, just to demonstrate the feasibility and the safety. And once you compare, you realize that it truly adds nothing. Yet again, I say this is small numbers. The other study by Kalarus is also small, but it highlights again the same things, that these are the patients you fear the most. So once you're performing complete revascularization, even in patients with diabetes, renal dysfunction, impaired LV function, you realize that there are benefits and you should not necessarily restrict yourself. But let's go beyond these 214 patients and 69 patients, and here is a meta-analysis, again suggestive, almost 30 trials reviewed, demonstrating that a complete revascularization is possibly the way to go. And this is the largest series, 39,000 patients from 14 trials, 4 randomized, 14 non-randomized, and once you compare, there is once again data suggesting that you are much better off. So the observations from PRAMI are not necessarily restricted. There is wisdom, there is lots of additional benefits, and we should not necessarily be afraid that you are going to worsen the patient's renal status or something else. Now, beyond that, I'd like to take you to my own experience. This is the SINCERE database, STEMI only practice for 12 years. 38% of the patients over the last 10 years have been done who were unfunded, without insurance, no payments coming from the hospital. And the SINCERE database has performed STEMI interventions in possibly the biggest uninsured population in the world. There are a straightforward index procedure is performed, and for several of them, a second stage procedure is performed because these patients are unlikely to be coming back because of lack of insurance. And let's take you to the important lessons learned through SINCERE. So this is possibly the biggest lesson. Here you go. Number of these patients in 12 years performing STEMI only, culprit or doing additional procedures. How many of these ended up going to surgery, which is what is bringing you up to the status of PCI today, 0. No patients over a 12-year span ends up going to surgery. And for all of these in which a second procedure was done, I've used the guide wire as the criteria. Almost universally, the same guide wire which was used for the primary intervention is also successfully used to perform what is often a straightforward 5-minute procedure. But there are caveats, and this, I think, are the 2 absolute requirements which are required whenever you are performing a complete revascularization. Number 1, the result of the index STEMI procedure has to be perfect. You need to have both a TIMI-3 flow as well as a myocardial perfusion grade 3, and the second, or the non-culprit lesion, has to be technically simple. I think once you go into all these complex cases, if you are trying to do bifurcations and all the fancy things, that's where you get into trouble. So at the end of it, what do you make? I think this is precisely the situation where there is going to be clinical judgment, which is paramount, and you probably need to approach them with much maturity and restraint. So what's the final word? Trials which are not big enough, meta-analysis which do not necessarily give you all the right answers in a retrospective fashion. So this is one of the editorials which I thought is possibly the most pertinent. This is after comparing the large data from the Swiss AMIS registry, and I quote Dr. Smith for you. From this large-scale registry, it does appear that you are able to do complete revascularization, which is potentially cost-saving and much more patient-friendly. However, I do believe, as Dr. Grind's last slide mentioned quite correctly, that we need much more data. You cannot make evaluation on the basis of 60, 80, or 200 patients. And now we've got 7 large randomized trials, including the study from Canada, hopefully, I think, which will help us answer this very important question. So this, Cindy, is the guidelines. 2013, which you also mentioned in your last slide, PCI should not be performed. However, I think this is more relevant when we used to use balloon angioplasty. When Samin did his first course here using a non-compliant balloon and DCA, I think a lot has changed since that time. PCI has become simple, and the second lesion in the majority of the cases is no big deal. So here is my prediction, Cindy, what is going to happen. I think in 2016, I think this is all gone. And possibly on the basis of just the importance of performing the second procedure, I think this is the guidelines in 2016 that I think you'll probably have a class 2 indication and that we will be performing a complete revascularization. Thank you.